Hello and welcome back to the Biochemistry for Health Sciences channel. In today's video, we shall look at isoenzymes. In the previous videos, we talked about various ways by which our body can use in order to regulate enzymes. And today we shall look at yet another way, and that's the use of isoenzymes. First of all, what are isoenzymes? So isoenzymes are different forms of an enzyme. They basically catalyze the same biochemical reaction. However, they have different amino acid sequences and therefore different chemical, physical, as well as immunological characteristics. Let's look at two examples, lactate dehydrogenase as well as hexokinase isoenzymes, in order to appreciate the nature as well as the importance why our body has isoenzymes. For lactate dehydrogenase, we have 5 common isoenzymes, and these are called LDH1 to LDH5. They all catalyze the same reaction, and that's the interconversion between pyruvate and lactate. All of these isoenzymes are tetrameric enzymes. There are 4 subunits, which are made from 2 types of subunits, M as well as the H. So LDH1 is HHHH. LDH2 has 3H and 1 M subunit. LDH3 has 2H and 2 M subunits. LDH4, 1H and 3 M subunits. And LDH5 has all 4 M subunits. Let's compare LDH1, or the H4 subunit that is very rich in the heart, with LDH5, or the M4 subunit, which is predominant in skeletal muscles, in order to appreciate the differences between isoenzymes as well as the similarities between isoenzymes. As mentioned before, they catalyze the same reaction. However, LDH1 has a lower Km for pyruvate and lactate compared to LDH5. LDH1 is sensitive to substrate inhibition by pyruvate. However, LDH5 is not affected by pyruvate. In addition, LDH1 is also affected or inhibited by high concentrations of lactate. However, there's much less substrate inhibition by lactate for LDH5. So these properties suggest that LDH1 is more suited for oxidation of lactate to pyruvate, while LDH5 is more suited for reduction of pyruvate to lactate. However, this may not be entirely true. It's not that LDH1 is more suited for oxidation reactions, while LDH5 is more suited for reduction of pyruvate to lactate. Rather, it seems like LDH1 has a better response to small changes in glycolysis rate, and it's something you see in the heart where the oxygen concentration doesn't vary significantly, and therefore the rate of glycolysis doesn't vary significantly. However, in skeletal muscles, LDH5 seems to respond better to large changes in glycolytic rate because the oxygen concentration can vary dramatically in skeletal muscles, and therefore glycolysis rate can vary dramatically. And under these conditions, it looks like LDH5 is a better enzyme compared to the other isoenzymes of LDH. So in summary, different isoenzymes seem to work better in different tissue environments. That's why LDH1 is predominant in the heart, while LDH5 is predominant in skeletal muscles. In addition, isoenzymes may be more suited for the organ's function. So let's look at liver hexokinase 4, also called HK4 or glucokinase, and let's see why this hexokinase isoenzyme is suitable for the function of the liver compared to other hexokinase isoenzymes. So while most cells have hexokinase 1, 2, and or 3, the liver as well as the beta cells in the pancreas have predominantly the hexokinase 4 isoenzyme, which is also called glucokinase. All of these enzymes, isoenzymes, catalyze the same reaction, that is reaction number 1 in glycolysis, where glucose reacts with ATP, glucose gets phosphorylated to glucose 6-phosphate forming ADP. So how does the presence of this isoenzyme glucokinase help in the function of the liver? Now, one of the important differences between glucokinase as well as the other hexokinase enzymes is the Km for glucose. Glucokinase has a much higher Km, around 5 millimolar for glucose. Therefore, it has a lower affinity for glucose, while the other hexokinase isoenzymes have a very low Km for glucose, less than 0.3 millimolar, which means they have a higher affinity for glucose than glucokinase. So what is the physiological importance of this difference in Km between glucokinase and the rest of the hexokinase isoenzymes? So after a meal, the glucose concentration is the highest, about 8 to 10 millimolar. And when the concentration is very high, so we are talking about 8 to 10 millimolar, somewhere here, we can see that the rest of the hexokinase are saturated and are working at maximum capacity to take in glucose, while the glucokinase is also working very well to take in glucose, but it's not saturated. So this means after a meal, when the glucose is very high, that glucose will enter not only all the other cells, but also will enter the liver as well as the beta cells in the pancreas, because at this concentration, we can see from the glucokinase curve, it is working quite fast, close to 100% maximum velocity. Note that the transport protein that brings in glucose into the liver cells, which is GLUT2, also has a very high Km for glucose, which means it works very well only when the glucose concentration is very high. It will bring in glucose into the hepatocytes very well only when the glucose concentration is very high, and the only time the glucose concentration is very high is after a meal. So to summarize, after a meal, all cells would be able to take in blood glucose because of the high glucose concentration, and this also includes the liver cells as well as the beta cells found in the pancreas. Now, during starvation periods, for example, 2-3 in the morning when you are fast asleep, the glucose concentration is much lower. So we are talking about 3 to 4 millimolar. So we are somewhere around here. And you can see at low glucose concentration, the rest of the cells are able to take in glucose because the hexokinase has a very low Km. So you can see they're working at 100% Vmax. However, for glucokinase, we see that this enzyme present in the beta cells of the pancreas as well as the liver hepatocytes is working only about, maybe about 30% Vmax due to its very high km for glucose. So this means during starvation periods, the GLUT2, again, because of its high km, is not transporting enough glucose inside the hepatocytes, and also because of the high km of glucokinase, it's not working very rapidly. It's only working about 20-30% of its Vmax. Therefore, the small amount of glucose is really not entering appreciably the liver cells, and instead it will enter the other cells that desperately need glucose, and that's especially the brain as well as the red blood cells. The brain and red blood cells have hexokinase enzymes that are very, very low km, and therefore they should be able to take in this limited amount of glucose during starvation periods. So this is a very important physiological function of the liver. We don't want the liver to compete with the brain as well as the red blood cells when there is very low blood glucose concentration, and that's something we see during the starvation state. Now, besides the Km difference between glucokinase and hexokinase, there's another very important characteristic about glucokinase that you find in the liver, and that is the presence of a protein called glucokinase regulatory protein, or GKRP. And this protein, GKRP, binds glucokinase and can send the glucokinase into the nucleus. So remember, glycolysis happens in the cytoplasm, and that's where we need glucokinase. However, this protein can actually bind glucokinase and transport it into the nucleus. So during starvation periods, the glucokinase regulatory protein, GKRP, will bind the GK, glucokinase, form this complex, and this complex will then be transported from the cytoplasm, where glycolysis occurs, into the nucleus. So basically, the glucokinase is sequestered in the nucleus during starvation, and therefore, since we don't have glucokinase in the cytoplasm, glycolysis would start slowing down during starvation periods. So remember, during starvation periods, the liver is actively breaking down glycogen to give you glucose, so that this glucose can be exported out into the bloodstream for use by the brain and the red blood cells. Gluconeogenesis, the synthesis of new glucose, is also another very important metabolic pathway that happens during starvation. New glucose is made by the liver, and this glucose, once again, can be used by the brain as well as the red blood cells. So one of the intermediates of gluconeogenesis is fructose 6-phosphate. Now, fructose 6-phosphate, this gluconeogenesis intermediate, fructose 6-phosphate, actually stabilizes this complex formed between glucokinase and the regulatory protein, GKRP. So fructose 6-phosphate stabilizes this complex. So this gluconeogenesis intermediate makes this complex stable, and thereby stopping the activity of glucokinase. And then this complex is transported from the cytoplasm into the nucleus. Now, after a meal, we have high glucose, and as we mentioned earlier, this glucose will enter the hepatocytes, And there is also fructose in the meal, and the fructose will be taken into the hepatocytes and converted into fructose 1-phosphate. Now, fructose 1-phosphate as well as glucose, these two chemicals actually disrupt the GK-GKRP complex. So this complex is actually broken down into the respective components by the presence of glucose as well as fructose 1-phosphate. And this complex will then be transported from the nucleus into the cytoplasm. So from the nucleus, the disrupted complex will be transported out, and now we have glucokinase present in the cytoplasm, and this glucokinase will allow glycolysis to happen. So to summarize, this glucokinase enzyme that you find in the liver cells is very suitable for the function of the liver. The high Km as well as the presence of the protein GKRP ensures that the liver only takes in glucose from the bloodstream when the glucose concentration is high, and that happens only during or rather after a meal. However, when the glucose concentration is low, the liver will not take up glucose from the bloodstream, and it will leave the glucose for the brain as well as the red blood cells. It's not surprising that glucokinase regulatory protein is being considered as a target for diabetes therapy, since it has a very important role in helping the liver maintain blood glucose concentration at the appropriate amount during starvation time as well as postprandial situations. Okay, so now let's look at a few examples, a few clinical applications of isoenzymes. Let's look at the lactate dehydrogenase isoenzymes. LDH1, also called H4, this is predominant in the heart and red blood cells. LDH2, found in large amounts in the reticular endothelial system as well as red blood cells. 3 is predominant in the lungs, 4 in the kidneys, placenta, and pancreas, and 5 in the liver as well as striated muscles. So quite often when we see that the patient's total LDH activity is high, so if the normal range is about 50 to 200 units per liter, and in this patient we see the LDH is very high, 602 units per liter. So the question the physician, the clinician wants to ask is, where is this LDH coming from? Where is this excess LDH coming from? So by doing an isoenzyme analysis, and typically that is done by electrophoresis, we can separate the isoenzymes of lactate dehydrogenase by using electrophoresis, or often agarose electrophoresis is what we use in the clinical setting. And by measuring the intensity of each of these bands, we can determine the percent of each isoenzyme that is found in this total activity. So normally LDH2 is higher than LDH1, and then we have LDH3, and then 4 and 5 is in much smaller amounts. So in this patient, we see that the LDH1 is increased, the LDH2 is increased a little bit. So this likely shows that the LDH is coming probably from the heart or the red blood cells. So this heart, some cells in the heart or the red blood cells are being damaged, and they are leaking out LDH into the bloodstream. Now, typically we see that LDH1 is lower than LDH2. So if we take the ratio of LDH 1 to 2, this ratio should be less than 1. So one of the important uses of the aldolase isoenzyme test is in acute myocardial infarction or heart attacks. This ratio, which is usually less than 1, may flip. The ratio may become more than 1, usually after 12 to 24 hours. This, however, is not a specific test for myocardial infarction because this can happen in many other diseases. So hopefully, besides LDH as well as the isoenzymes, the other tests might show exactly where the problem is in this patient, whether it's something with the red blood cells or the heart cells or both the cells are being affected. Another application of isoenzymes is creatine kinase isoenzymes. Now, creatine kinase is an enzyme that catalyzes this reaction between creatine and ATP, forming creatine phosphate and ADP that we see in muscle cells. There are 3 isoenzymes of creatine kinase. MM is the major form that we find, 97%. 2 to 3% is the MB form, and less than 1% is the BB form. So normal creatine kinase electrophoresis would look something like this: a huge band for MM and very, very minor bands for MB and BB. The main use for creatine kinase isoenzyme clinically is again in myocardial infarction or heart attacks. During an MI, the CKMB, this fraction here, will become greater than 5%. So this isoenzyme will start increasing, and once it's more than 5%, that's a good indication that a heart attack might have occurred. Once again, like LDH, this is not a specific test. CKMB is not a specific test. This can increase in several other diseases besides myocardial infarction. Another problem with the CKMB test for myocardial infarction is that this is not a good test for someone coming to hospital 36 hours or more after a chest pain, because by this time the enzyme CKMB, which will slowly increase, it would probably have come back to normal values before 36 hours. So that means this is not a good test for someone coming to the hospital long after a chest pain. This is also not a good test, as CKMB, creatine kinase MB. It's not a good test if somebody had a minor attack, heart attack, that will only slightly increase the MB. But if they also had skeletal muscle injury. So, for example, someone who had surgery of the muscles, trauma, or strenuous exercise. Because when under these conditions of skeletal muscle injury, the MM will rise tremendously. And so the MB might rise a little bit, but this ratio will not be more than 5%, although the person had a heart attack. So that might be a misleading lab value, because this person may have had a heart attack, but because the MM is so high, the value did not increase more than 5%. Now, CKMB, however, is a good test for diagnosing early stage MI. So 6 to 10 hours after the MI happened. And this is important because one of the treatments for myocardial infarction is the use of thrombolytic therapy. In this therapy, we use clot-dissolving drugs. These drugs help dissolve the clot that is blocking the coronary vessel. So this therapy gives the best results if it's delivered very soon after the vessel is occluded. So in this respect, CKMB can be a good test for starting thrombolytic therapy. Similarly, this CKMB test is also a good test for confirming the effectiveness of this thrombolytic therapy, these clot-dissolving drugs that are being given to patients with MI in order to remove the obstruction in the coronary vessels. CKMB is also a good test for patients with reinfarction, since the MB values will come back to normal after 3 days. So somebody had a heart attack and a few days later had another heart attack, the CKMB will once again rise. So this is also a good test for reinfarction. Another clinical application of isoenzymes is PD isoenzymes, phosphodiesterase isoenzymes. Now, phosphodiesterases are enzymes that break down either cyclic GMP into 5' GMP or cyclic AMP into 5' AMP. As we shall see later in cell signaling, cyclic AMP and cyclic GMP are very important second messengers in cells. They affect all kinds of enzyme functions and thereby all kinds of biological processes. There are several types of phosphodiesterase isoenzymes, roughly about 7 families, and some of these families even have subtypes. So some of these isoenzymes, like the 5, 6, and 1, work very well with cGMP. They basically catalyze this reaction very well. Others, such as 3, 4, and 7, will catalyze the breakdown of cyclic AMP very well. So let's look at an application, and this is in the treatment of erectile dysfunction with the drug Viagra. So this specifically, we are dealing with the isoenzyme PDE5. So in the blood vessels, in the endothelial cells that are lining the blood vessels, these cells, or the blood vessels in the penis, we see nitric oxide formation by the enzyme nitric oxide synthase. So nitric oxide is formed in these endothelial cells of the blood vessels in the penis. So this nitric oxide will then diffuse to the smooth muscle cells, so to these smooth muscle cells of the blood vessels, and there in the smooth muscle cells, the nitric oxide will bind to the enzyme guanylyl cyclase. This guanylyl cyclase enzyme will become stimulated, and this enzyme will convert GMP into cyclic GMP. And this cyclic GMP now will cause relaxation of smooth muscles in the blood vessel wall, and that will lead to vasodilation. The blood vessel radius becomes bigger, and that will lead to erection. So basically, the presence of cyclic GMP as an intracellular messenger will cause erection. Now, this enzyme PDE5 is predominant in the penis tissue, and it will break down this cyclic GMP into inactive 5' GMP, and that will remove the erection. So the drug sildenafil, or brand name is Viagra. What this drug does, it basically inhibits this phosphodiesterase 5 isoenzyme. And by inhibiting this isoenzyme, the cGMP is not broken down into 5' GMP. That means the concentration of cGMP will remain very high. So this concentration will remain very high because this enzyme is being inhibited, and that will lead to sustained smooth muscle relaxation, sustained vasodilation, and therefore sustained erection. So this is how Viagra helps in the treatment of erectile dysfunction. Another clinical application of isoenzymes is the cytochrome P450 monooxygenase isoenzymes, or what we call as the CYP isoenzymes. Now, most of the drugs that we take, as well as foreign chemicals, including things like pollutants, these chemicals are metabolized by the CYP enzymes. These enzymes typically require the reducing agent NADPH as well as oxygen as substrates, and we call these metabolic reactions the phase 1 reactions. CYP enzymes are found in the membrane of the smooth endoplasmic reticulum of many different cell types, but especially predominant in the liver, in the hepatocytes. So basically what these enzymes do is they add certain groups, such as the hydroxyl group, to the foreign chemical or to the drug. They might oxidize the drug, they might hydrolyze the drug. These are all common phase 1 reactions. And these chemical modifications, such as hydroxylation, oxidation, or hydrolysis of the foreign chemical or the drug, will increase the hydrophilicity of the drug, make the drug or the foreign chemical more water soluble. And that way the kidneys can get rid of this chemical that's not supposed to be in the body. There are numerous isoenzymes of cytochrome P450. This one here, CYP3A4, makes up about 1/3 of the cytochrome P450 enzymes and is responsible for the metabolism of almost 60% of all drugs that patients take. Now, patients who are on some sort of drug therapy, they are usually instructed not to take grapefruit juice, because grapefruit juice contains chemicals that are potent inhibitors of CYP3A4, and by taking grapefruit juice, this enzyme would be inhibited. It would not be able to metabolize the drug, and the concentration of the drug in the bloodstream of the patient may rise to very high levels, and that might lead to unpredictable side effects. There's another isoenzyme called CYP2C9, and this is involved in the metabolism of a very common blood anti-clotting drug called warfarin, as well as the anti-epileptic drug phenytoin. So these cytochrome P450 enzymes, not only do we see a lot of isoenzymes, but many different subtypes or isoforms in different individuals. And this explains the variations in drug metabolism that we see among healthy individuals. Someone might take 1 aspirin and the headache goes away. Another person might take 2 or 3 aspirin and nothing happens. And in sick patients, these variations may even become more dramatic. So here's an application of isoenzyme in a genetic disease. So if we look at this reaction here in glycolysis, this is catalyzed by the enzyme aldolase. Basically, fructose 1,6-bisphosphate is broken down into dihydroxyacetone phosphate, DHAP, as well as glycerolide 3-phosphate. There are different types of aldolase isoenzymes. Aldolase A is present in embryo, muscle cells, and red blood cells. B is rich in liver, kidneys, and small intestine, and C is predominant in the brain. So in case of this genetic disease, aldolase A deficiency, also called glycogen storage disease type 12, GSD12, also called red cell aldolase deficiency, because A is found in muscle cells and red blood cells. What we see is hemolytic anemia. Red blood cells are broken down, leading to anemia. We also see problems with energy generation in the muscles. So there is muscle damage, myopathy or rhabdomyolysis, muscle cells breaking down due to insufficient energy production during glycolysis in the muscles. Muscles are rich in myoglobin, and myoglobin is sort of if you remember, is a heme protein, just like hemoglobin is a heme protein. It's sort of reddish in color, and myoglobin is quite small, so it gets readily filtered and excreted by the kidneys. And in this case, we can see the urine becoming slightly pinkish red because the myoglobin that's coming from the damaged muscle cells is being excreted into the urine. And that's called myoglobinuria. When large amounts of myoglobin enter the kidneys, in the tubules of the kidneys, it can clog up the tubules and cause acute kidney damage. So this can be a very dangerous situation. Another application of isoenzyme in a genetic disease, and this is phosphofructokinase isoenzyme for this disease called GSD7 or type 7 glycogen storage disease. As we mentioned in earlier video, phosphofructokinase is the enzyme that catalyzes reaction number 3, where fructose 6-phosphate reacts with ATP to form fructose 1,6-bisphosphate and ADP. And recall that this is the committed step for glycolysis. There are 3 major isoenzymes of PFK, one that you find in the liver, the other mostly in the muscles, and the third one in platelets. In type 7 glycogen storage disease, or GSD7, also called thyroid disease, the muscle PFK is the one that is defective. So this genetic defect affects the gene for the muscle PFK. So once again, now if the PFK is affected in the muscle, then the muscle cannot carry out glycolysis, and that would lead to impaired energy production in the muscle. And during vigorous exercise, there could be cramps as well as muscle breakdown, and that would release myoglobin into the urine, and that may lead to acute kidney damage. So hopefully these examples of isoenzymes give you a good appreciation of the importance of isoenzymes, not only in normal metabolism in a human body, but also in the clinical applications. So in the next video, so we are done with this part here. We talked about how the body can change the catalytic activity of existing enzymes. In the next video, we'll see another way to regulate metabolism is to change the amount of enzymes. And this can be done by either affecting the synthesis of new protein molecules or by affecting the degradation of existing molecules. So until the next video, once again, thank you very much for watching this channel, and have a wonderful day, and hopefully we'll see you in the next video.